Good evening, and welcome to the Greenwich Hospital webinar of Understanding Total Joint Replacement Surgery. My name is Annie Nardi. I am the Director of Clinical Programs here at Greenwich Hospital, and we are so thrilled to have you join us for this program tonight. The goal of this webinar is to discuss total joint replacement surgery, including total hip and knee surgery, as well as revision surgery. We have three fantastic surgeons with us tonight from Yale Medicine, ONS, and WestMed Medical Group, as well as members of our very own Greenwich Hospital Total Joint Replacement team. We are excited for you to hear about the comprehensive program we provide here at Greenwich Hospital. You'll hear about the personal attention you will receive both before and after joint replacement surgery. You'll also hear about the latest pain management techniques, physical therapy, as well as the excellent nursing care you'll receive within our care here at the hospital. If you have any questions for our presenters this evening, please use the Q&A box at the bottom of your screen. We will be able to answer them live during the webinar, and then we'll also have some time at the end of the program for additional questions. So let's get started. For our first presentation, we are going to have Dr. Kevin Chu from Orthopedic Neurosurgery Specialists, better known as ONS, to discuss total hip replacement surgery. Dr. Kevin Chu is a board-certified orthopedic surgeon who specializes in primary hip and knee replacement for the treatment of degenerative osteoarthritis, inflammatory arthritis, avascular necrosis, hip dysplasia, and post-traumatic arthrosis. He is fellowship trained in direct anterior hip replacement, the use of computer and robotic-assisted technology, and partial knee replacement. His clinical interest also includes revision hip and knee surgery for the treatment of failed joint replacement due to infection, loosening, or recurrent dislocation. Dr. Chu earned his medical degree from the University of Chicago and completed his internship and residency at the University of California in San Francisco. He received his fellowship training in adult reconstructive and joint replacement at the Rothman Institute in Philadelphia. And Dr. Chu has presented and published on such topics as the biology of bone healing, the reduction of opioid use after orthopedic surgery, periprosthetic joint infection management, and partial joint replacement. Dr. Chu was named an emerging leader by the American Orthopedic Association. He's also a reviewer for the Journal of American Association of Orthopedic Surgeons and the Journal of Orthopedic Trauma. He has also been named one of 2023's Castle Connolly Top Docs. So, without further ado, I will hand it over to Dr. Chu.
All right. Well, thank you, Annie, so much for the wonderful introduction, and thank you for the entire group and for Greenwich Hospital and Yale for having us and inviting me to talk. It's really our honor to participate and talk about the state of total joint replacements at Greenwich Hospital. I'll be speaking about total hip replacement surgery. Again, my background as an orthopedic surgeon and specialization in total joint replacements. I've been here operating at Greenwich Hospital for a little bit more than 4 years, and it's been a really great experience working with the entire team and providing care for our community. So to begin, we'll talk about hip arthritis. We'll also discuss various treatment options and then obviously focus on hip replacement surgery. So to understand hip arthritis, it helps to begin with understanding the anatomy. So at a very basic concept, a hip joint is like a ball in a socket. So if you consider that the ball is the uppermost portion of the femur, known as the femoral head, and then the socket is the acetabulum, which is essentially part of the pelvis. These diagrams can show what happens when we transition from a healthy hip socket joint to one with osteoarthritis. So on the left, you can see a normal hip joint. Again, the femoral head is the ball of the ball and socket joint, and then the acetabulum is the socket. And you can see a nice thick layer of cartilage, which is known as articular cartilage, in between. As we progress in age to osteoarthritis and degenerative conditions of the hip, we see changes to the cartilage thinning, as well as asymmetry and asphericity of the femoral head, and formation of bone spurs and loss of the normal joint space. The image to the right shows what this looks like in gross. There's multiple types of arthritis, although by far the most common is osteoarthritis, which we also know as degenerative arthritis. Whether it be from inflammatory arthritis, infection, or trauma, ultimately these can lead to a loss of the normal articular cartilage, as well as underlying bony changes. And for many people, this can cause pain, stiffness or limited range of motion, and overall a decrease in function. These are two x-rays which also show this. On the left, again, is a normal joint space. You can see the femoral head, which is the ball of the joint, and then the socket. There's an empty looking space in between those. It's not actually empty. That's the cartilage space. And so when you compare that to the right-hand image, you can see the primary feature of joint space narrowing, as well as, like I mentioned previously, asphericity of the femoral head and formation of bone spurs. In terms of non-surgical treatment for severe hip osteoarthritis, much of this is from our main professional organizations. It typically begins with a combination approach with the use of non-steroidal anti-inflammatory drugs, activity modification, physical therapy and home exercises, injections, weight loss, and the temporary use of an assisted device. In terms of the surgical treatment, we found that total hip replacement is the best option for this. When is it time to talk about surgery? So this is really a personal decision, and this is one we often have in the office. Our criteria for appropriate timing typically involves a combination of having both clinical and radiographic evidence of severe arthritis. Again, to the right of the screen, you can see an example of very severe hip arthritis with essentially complete loss of the normal joint space. And then perhaps even more important are patient factors. So we don't treat x-rays, we treat patients. And so we often ask about symptoms, in particular any daily symptoms, any severe limitations in quality of life. And this could be anything from work, recreation, travel. Everyone's different. We also want to make sure that people have attempted the appropriate conservative treatment, again, which would be things like physical therapy, anti-inflammatories, possibly injections, as well as weight loss. Now, ultimately, this is a quality of life decision. I tell patients in the office is that arthritis, thankfully, isn't a dangerous problem for the most part. However, when it begins to interfere with daily activities and quality of life, that can be a significant problem and lead to a decreased quality. What is hip replacement surgery? So this is a good video which shows what goes into the replacement. So here we can see severe right hip osteoarthritis in a patient, and ultimately the final product, which is the hip replacement surgery. This begins with anesthesia, typically a spinal anesthetic, which we'll hear more about. The incision is made over the hip joint, and then the ball of the ball and socket joint is removed. Following that, the socket is then machined to a smooth finish, and then a metal socket is inserted into the acetabulum. Into the acetabulum, we then insert a highly cross-linked, high-density plastic, and that completes the socket portion of the surgery. Now, to replace the ball, we have to actually implant that and anchor it into the femur. And so we excavate the femur to accept typically a trapezoidal-shaped prosthesis, which is then inserted into the top of the femur bone. Onto the taper of the femur, we then impact a ball. And as you can see, this is how we can recreate and replace an arthritic joint with what is essentially a smooth ball bearing. These prostheses have undergone significant changes over time. So the earliest hip replacements were actually performed in the late 1800s using ivory as the component. What we call modern hip replacement was really popularized in the 1950s using metal and plastic. And now we have on the right-hand side what would be an example of a modern hip replacement prosthesis. Perhaps the most important change that's gone into both hip and knee replacements has really been the rise of what we call rapid recovery protocols. And this is really a team-based approach, and so it's really wonderful we have our entire team here to talk about this from multiple aspects. And this really begins in the preoperative setting. So patient education, talking with your surgeon is very important to understand the surgery itself and what to expect before, during, and afterwards. We often combine this with what we call prehab, which is preoperative physical therapy, so patients can learn exercises before the surgery, which helps them hit the ground running after the procedure. We use modern anesthesia techniques, which often combines a neuraxial or spinal anesthetic with the combination potentially of regional nerve blocks. Surgical techniques have been designed to reduce soft tissue trauma, and we have special medications and machines which help us to reduce intraoperative blood loss. And then this also extends to the postoperative care, where this is maybe the biggest change in terms of the focus on early mobilization. So we really make a strong emphasis on early mobility after surgery. Patients are walking typically within 6 hours of the surgery in the hospital. Most patients are being discharged to home, which is a huge change over the last few years. And this is accomplished through the physical therapy team, nurses, nurse navigators, and the multimodal analgesia that our anesthesia colleagues help to provide. In terms of technical aspects that have changed, patients often ask what has been a large change to the implants. And I think perhaps the most important of this was the development of what's called highly cross-linked polyethylene, which is the highly dense plastic. So with this has been a significant increase in the longevity of hip replacements. There have also been iterative changes to the design of the femoral prosthetics. So to the bottom right, you can see some different size implants. The general trend has been to move to slightly smaller or bone-sparing prostheses. The rise of the use of biologic ingrowth or on-growth materials. So if you look at those prosthetics to the bottom right, you can see they have a roughened texture. This is deliberate. So your bone is actually ingrowing or on-growing onto the metal, which is what provides long-term stability. We also incorporate the use of modern robotic and computer-navigated techniques. And again, as I mentioned, perhaps the most important has been the rise of the rapid recovery protocols and even the potential for same-day discharge for certain patients. I briefly also want to talk about various approaches to the hip, as this is probably the number one question that I receive in the office most commonly. I think the number one thing to take away, just to say this at the beginning, is that total hip replacement surgery is extremely effective. These are multiple approaches you can see on the left-hand side, and in general, they actually all provide an excellent outcome. So the most important aspect of the surgery is not really the approach you use, but more to get to the final outcome on the right, which is a well-sized and positioned total hip replacement prosthesis. In terms of some of the data that looks at this, we typically have been looking more recently at comparing different approaches for longevity and success rates. Perhaps the best studies for this are large national registries. So this is a large study from Norway with over 20,000 hip replacement surgeries with a medium-term follow-up. And this study looked at the survivorship, which is essentially the longevity of hip replacement surgeries, comparing various techniques. This is a graph which shows what we call a Kaplan-Meier curve, which is essentially a survival curve. So survivorship, obviously, you want to be as close to or near 100%. And we show pretty amazingly, regardless of how you approach the hip, either through the front, the side, or the back, it has an amazingly high success rate overall in the high 90s. And this study found no significant differences among the surgical approaches at short and midterm follow-up. There were some small differences in this study, including small differences in terms of infection as well as dislocation, but overall, a pretty amazing result that there were no significant differences. This leads us to an even larger study, which came to us from Australia with over 120,000 hip replacement surgeries, again, mainly looking to compare survivorship of hip replacements. And if you look again at this overall success rate, or the rather conversely, the cumulative percent revision, it's remarkably similar. So we pretty confidently know now that there's no long-term differences in overall risk for failure when you compare various approaches to the hip. This study found slight differences in terms of the type of revisions based on the approach, including differences for femoral component loosening, infection, dislocation, fracture, and infection again. But overall, these were very small differences. And when you take a closer look at the data, there were very small absolute changes in risk reduction or elevated risk between them. So why would one choose one versus the other? So I'll talk briefly about a couple of studies. Mainly this one here, which is from the Mayo Clinic, which was a randomized controlled trial comparing anterior and posterior approach. And it's a pretty amazing study. So in the study, 116 patients were randomized to either an anterior approach or a posterior approach. And if you can imagine being enrolled in a study, you essentially would have agreed to have a hip replacement and not know how it would be done until you woke up after the surgery, which is amazing that a study like this could even be done. At least in this study, they found that there were some small changes in regards to early mobility. So perhaps some small changes in terms of use of a walker or a gait aid, use of stairs, opioid consumption, and decreased pain. But importantly, there were no differences in patient-reported outcomes, which are perhaps the most important way that we gauge the clinical success of various techniques. No differences in radiographic parameters, and again, no changes in complication rates. And so my take home from this is that there really isn't a significant difference when you compare these different approaches, possibly some early functional benefits, but that really is being studied further in the literature. Some limitations to the anterior approach, and a lot of this is from my own experience as an anterior hip surgeon. The location of the incision is near the groin, and so for patients with any infection or rash toward the groin or inguinal area, or a patient with a morbidly obese body habitus, it may be prudent to consider an alternate approach to reduce the risk for infection. It's not very commonly used for revision surgery or complex reconstructions, namely because we have to access the surgical hardware from another approach typically, and so we would just use the same surgical incision to do the surgery itself. And then again, in my own personal experience, the anterior skin incision is slightly more visible, and so while the incision is the same size, people just notice it more, and so perhaps there are some cosmetic considerations for that as well. Overall, though, the surgery is incredibly successful. It's really important to have a great team, and we have a wonderful team here at Greenwich Hospital to get patients through the preoperative, intraoperative, and postoperative settings. The Lancet, which is a prestigious medical journal, called hip replacement surgery the operation of the century, and I think this is because it really is a curative procedure for hip arthritis while offering a relatively low complication rate and a high success rate overall. As I mentioned previously, rapid recovery protocols have really been revolutionary in terms of the postoperative care for the patients and increasing their mobility. It's reduced the requirement to go to nursing facilities after surgery and has reduced hospital length of stays. Last, it's important to talk to your surgeon about what approaches or prostheses or other surgical considerations are appropriate. There's really no one-size-fits-all treatment. Thank you.
All right. Thank you so much, Dr. Chu, for that wonderful update on total hip replacement surgery. I'm sure our participants will have plenty of questions for you, so please stick around. Next up, we will have Dr. Christopher Mattern from WestMed Medical Group, who will review recent advances in total knee replacement surgery. Dr. Christopher Mattern is a graduate of Princeton University, where he graduated summa cum laude with a degree in molecular biology, Phi Beta Kappa in 1999. He is a graduate of Columbia Medical School and Columbia Business School with his MBA with honors in finance in 2004. He completed his residency at the Hospital for Special Surgery in 2009. Since 2009, Dr. Mattern has worked for the WestMed Medical Group and currently serves as the chairman of orthopedic surgery. He specializes in shoulder, knee, and hip surgery, as well as sports medicine and, of course, joint replacement. He is married to Sarah and have two beautiful boys, Charlie and Max, and his interests include fitness, sports with his boys, volunteering, and consulting. Dr. Mattern?
Thank you, Annie. Thanks for that introduction. And I'm excited to be here with a great panel. It was a great talk, Kevin. Very informative, and I appreciate that. Today, what I'd like to talk about is advancements in knee replacement. So what I would like to start off with is just a set of objectives. I think it's important to understand what knee arthritis is. And then we're going to move on to reviewing some details about knee replacement surgery. And then we'll explore some recent advancements in knee replacement surgery. I have no disclosures related to this talk. So to start off, we'll talk about knee anatomy. The knee is a very complex joint, whereas we just heard about the hip as being a ball and socket joint. The knee has a few more degrees of range of motion in terms of it bends, it rotates, it translates, it moves side to side. It has compressive forces, it has distractive forces. And when we think about the anatomy, there's really three main bones we think about, and one is the femur, which is the end of your thigh bone, the tibia, which is the top of your shin bone, and then your kneecap, or what we call the patella. What caps the ends of the bone is cartilage, which is the cushioning material that helps give a smooth ride on the knee when you bend and straighten the knee. And what keeps this all together, in part, are the ligaments. There are four main ligaments in the knee, and then muscles are what allow us to move the joint. And then to help protect the cartilage, there's the meniscus, which are two C-shaped structures, and they fit inside the knee. So in knee function, we all rely on our knees pretty significantly throughout the day. When we walk, the reactive forces that go through the knee are about 850 newtons, or better understood as roughly 1/2 your body weight. The knee allows us to bike. That also requires about 1/2 your body weight. Now, going up and down stairs, which is where a lot of people will complain of pain in their knee when they have a disorder of the knee, that requires roughly 3 to 3.5 times body weight, and roughly 5 times your body weight to go downstairs. And then when we get into more impact loading, things like jogging, up to 7 times your body weight can go through your kneecap joint. Squatting takes roughly that amount, and a deep squat can be up to 10 to 20 times your body weight. So no wonder people have knee pain out there. So one of the main causes of knee pain is knee arthritis, and that'll be sort of the focus of what we're going to talk about today. And in very general terms, knee arthritis is the wearing down of that cartilage, that really important material, which you can see on the bottom right, that helps cushion the knee and allows us to have a seamless motion throughout the knee. As Kevin mentioned, there are various types of arthritis. By far the most common is what we call wear and tear arthritis, or age-related arthritis, and that's called osteoarthritis. Less common are inflammatory arthritises like rheumatoid arthritis, and then you can also develop arthritis after an injury, or what we call post-traumatic arthritis. And the main symptoms that patients will often complain about with knee arthritis are things like pain, that's probably the predominant symptom, but also swelling and stiffness. Some patients will complain of mechanical symptoms like their knee gets stuck or locks on them or gives out. And then some patients will also complain that their knees look bow-legged, and that's the deformity aspect of it. And when we make the diagnosis of knee arthritis, we really start with clinical history. So we listen to the patient, try to understand what their symptoms are, and that gives us an idea of what we can eventually hope to help. Then we do a physical examination, which is to check range of motion and strength and find any areas of deformity or weakness. And then we rely heavily on x-rays, which you can see in the middle picture here. The left one shows normal joint space. That space is not empty. It's occupied by the cushioning material called cartilage. On the one on the right, you can see that that space has narrowed, and that's what we call osteoarthritis. So the treatment of knee arthritis, as with most orthopedic ailments, starts with non-operative treatment. So we talk about exercise, which can help build up strength and motion. We talk about formal physical therapy. We talk about weight loss in certain instances. We talk about oral medications like Tylenol or Aleve. We talk about injections like cortisone, which can help bring down inflammation. The so-called gel injections or hyaluronic acid can sometimes provide relief, as can relatively more recently used technique, which is platelet-rich plasma, where we inject some of the growth factors that are taken from your blood into the knee. Some patients will benefit from bracing. If the knee is unstable or deformed, sometimes a brace can help. And then there's very, very limited evidence for the use of like oral supplements. Those are your glucosamine and chondroitin, so-called laser therapy, acupuncture, insoles, and knee arthroscopy. Knee arthroscopy is a great operation if you have an acute meniscus tear, but it's not a great operation if you have knee arthritis. So when non-operative treatment fails, we consider surgical management, and we're going to sort of zero in on knee replacement surgery. On the x-ray on the right is an x-ray of a knee replacement, where the white is actually the metal that we use to replace the knee. And in between the two metal surfaces is plastic, which I'll get into in a minute. And the overall goal of knee replacement is to restore pain-free function, stability, balance, and motion of the knee joint. So in a schematic view, a knee replacement is basically we are resurfacing the femur, tibia, and the kneecap. So we're basically putting a metal cap on the end of the thigh bone, a metal cap on the end of the shin bone, and we're putting a highly cross-linked plastic in between. And then we're also putting a plastic button behind the kneecap in many instances. And one thing that comes up a lot is patients will ask, like, do you need a total knee replacement or can I get away with a partial knee replacement? And as you can see on the x-rays on the right, the patient on the left had a partial knee replacement where you can see just one of the compartments, the medial compartment, was replaced, and a more conventional total knee replacement on the right. And I've listed just some of the, pros and cons of each. With a partial knee replacement, it's a smaller incision and it's less invasive and it's a little bit of a faster recovery. It's questionable whether it's an easier revision or not. And it may lead to higher function because you preserve a lot of the ligaments like the anterior cruciate ligament and the posterior cruciate ligament. One of the downsides of a partial knee replacement would be that you can get arthritis in those other compartments that don't have a replacement in them. So for someone like has rheumatoid arthritis, which is a diffuse disease of the joint, a partial knee replacement might not be a great option. In total knee replacement, it does replace the entire joints, and we can correct deformity. So someone who is really bow-legged or knock-kneed is probably not going to do as well with a partial knee replacement because we can't correct that deformity. In terms of longevity, there's debate as to which would last longer. A well-done total knee replacement, as we're going to get to in a little bit, may last you 20, 25 years. One of the downsides of a total knee as compared to a partial knee is a total knee has a little bit longer recovery, and in some cases can be a more difficult revision. So overview of knee replacement. Generally, we use a regional nerve block and a spinal for the anesthetic, and we also use a lot of local injections to try to help target those nerves in and around the knee. It's on average, a standard initial knee replacement is about a 1-hour operation, so you're in the operating room for about an hour plus some anesthesia time. Most of these are done either as an outpatient or 1 to 2 days in the hospital. And we like to begin immediate rehab, similar to what Kevin mentioned in his talk. We like to get patients up and moving right away. And it's very important, probably even more important with a knee replacement, that rehab has to continue, both at home and as an outpatient with formal physical therapy. Like with a hip replacement, we allow generally immediate weight bearing, so you can walk right away, usually with a walker and then advancing to a cane. And then we do use post-operative pain medications. So some of the surgical details, the picture on the left shows an arthritic knee where that cartilage has worn out. In the middle is the surgical cuts that we make to basically clearly define the anatomy of the knee and create a surface to accept the implant. And then on the right is the prosthesis, which is a metal prosthesis on the femur and the tibia and a plastic in between and underneath the kneecap. The implants can either be held in place by cement or they can be uncemented, which means it involves your bone growing in and around the prosthesis. So I'll touch on a couple advancements in knee replacement. I don't want to spend too much on this because this is more anesthesia, but we do use multimodal pain management. We try to give patients medications before. We try to limit general anesthesia with nerve blocks. We try to block the sensory nerves so that the motor nerves that allow for you to straighten and bend your knee afterwards are in use and ready to use right away. And we try to minimize the use of opioids if we can. And again, early mobilization, I think, is very helpful for getting patients moving. Some other advancements from the surgical side, our incisions have probably gotten smaller over time. A smaller incision should lead to less pain. And in terms of advancements of the actual prosthesis, uncemented knee replacements in select patients may have longer lasting knee replacements than the cemented knee replacements. And that's because you get bone ingrowth, and that may last longer than some of the cemented implants. A hot topic that I get asked a lot about is robotics. Using robotics is essentially using a robot arm to help you execute your surgical plan. So it's not like the surgeon is sitting in a different room having a robot do the operation, but the robot helps guide you in your procedure by making the bone cuts perhaps more exact. So it can improve accuracy. It can allow for more customized implant positioning to your anatomy. It helps give us real-time feedback in the operating room of how that knee may function when it's up and being used. And it may also be a little bit less invasive and allow for smaller incisions. So with these pictures here, this is just a picture of one of the robots. And what you can see on the bottom here is the surgeon's hands coming in, and actually the robot is guiding them, but not doing the operation itself. So one of the questions I get is, well, is it any better? And I think it really depends on the study you read. Some recent studies have shown that there's really not a major functional difference or difference in patient satisfaction. And that study came out just a couple of months ago. And then a large meta-analysis from earlier this year didn't show any differences in clinical or radiographic results, and the operating room times were slightly longer. There were no differences in complications. So from my standpoint, I tell patients I think it's a great technology, and I think it has a lot of potential, and it allows us perhaps in the future to have more real-time feedback in the operating room and may make us even better surgeons down the road. We touched a little bit on implants, on how long implants will last. With newer surfaces, we have the metal on either side of the joint, but the actual plastic that's in between has shown better lasting characteristics by being highly cross-linked, and in some of the implants we use vitamin E, which can help make them last longer. And if you look at most registry data on knee replacements, the registry data shows 20 to 25 years out. These are knees that were put in 20 years ago. About 82% of them are surviving well without revision at this time. One of the other features, I think, of knee replacement that's come up and might be interesting for surgeons and patients alike are so-called smart implants. And what is a smart implant? It basically takes your total knee and it adds a little stem extension. And that stem contains sensors that capture information about your knee replacement, much like your dashboard captures information about your car. And at the current time, it gives the surgeon and the patient feedback on what their range of motion is, how far they're walking, how quickly they're walking, and how many steps they're using. And perhaps in the future, these smart implants will give us feedback on how that knee replacement is functioning. Is it loose? Is it functioning well? Is there signs of infection? And that might be something that these smart implants may allow for. In terms of advancements in rehab, a lot of this is just early mobilization. I think doing a lot of home PT can be very helpful. I tell most of my patients that 80% of your ultimate outcome with your knee replacement is going to be what you do at home. The physical therapy will guide you, but you have to be motivated. I think there's been a push toward using virtual rehab. I use that for some of the follow-ups for patients who come with longer distance to do their midterm follow-ups. And again, I think 80% of it is patient-driven. Now, some expectations. It's always important to know what to expect. We can talk about knee replacement a lot, but if you don't know what to expect after it, you could be surprised. So after surgery, we generally get patients walking the same day, certainly the day after surgery. We want patients to be off a cane by about 6 weeks, and many are well before that. For a left knee, patients can drive at 2 to 3 weeks. For a right knee, generally about 6 weeks. Most activities you can get back to in about 2 to 3 months. The more intense sports like tennis, skiing, and hiking may be about 6 months. We do allow for low and intermediate impact athletics such as tennis and skiing and hiking, but running is generally not advised. The ultimate outcomes are, highly dependent on pre-op function. So if you're in really good shape beforehand, you're much more likely to get back to your sports afterwards. And overall patient satisfaction rates for knee replacement are pretty high, probably not as high as hip with hip replacements, but they're pretty high at 80 to 100% depending on the study. And then I thought I'd just take a minute or so and go down what I Googled were the top 10 myths about knee replacement. So one myth that I came across was that success rate is low, and while it's not as high as hip replacement, it's still pretty high at 80 to 100% patient satisfaction. Another myth was complications. With any surgical procedure, complications can happen. Luckily, those are generally rare at about 5%. Some other concerns were bending and kneeling are difficult, and there's many variables to something like this. I think it depends a lot on your preoperative function, but most patients can get close to pretty near normal function afterwards. Patients raise concerns about, will they need a blood transfusion? 20 years ago, I would have said perhaps. Nowadays, generally with the use of various chemicals that we will give you at the time of surgery, the risk of needing a blood transfusion is probably less than 1 to 2%. Concerns about longevity. Patients always say, well, I read that it's only going to last 10 years. Well, most of them are actually functioning pretty well at 25 years. Number 6, after replacement, it can take years to recover. I would say on average, the average patient probably is in good shape doing most functional activities. I would say 90% of their day-to-day activities by 3 months. Number 7, it is not possible to undergo replacement for both knees at the same time. I do replacements for both knees at the same time in select patients. A lot of it's patient dependent. Generally, healthier patients is a prerequisite. It's not possible to drive after a knee replacement. Most patients are driving by 6 to 8 weeks. I get this a lot. I'm too old or I'm too young for knee replacement. And unfortunately, we do see knee arthritis in a young population, especially post-traumatic or post-ACL injuries. But age, I say, is just a number. It really depends on your overall health and your overall fitness level. And last but not least, the knee can reject the implant. That has been documented. It's rare for most patients. But for patients who have concern or documented metal allergies, we have alternatives that are hypoallergenic and less likely to cause any rejection. Thank you.
Thank you so much, Dr. Mattern. I really loved those myths. Way to debunk them. Thank you for sharing. All right, next up, we have Dr. Thomas Hickernell from Yale Medicine to discuss total joint revision surgery. Dr. Thomas Hickernell is an orthopedic surgeon specializing in adult hip and knee reconstructive surgery. He attended medical school and completed an orthopedic surgery residency, followed by a fellowship in adult hip and knee reconstruction surgery at Columbia University Medical Center. He was an assistant professor of orthopedic surgery at Columbia and New York Presbyterian Hudson Valley Hospital before joining us with Yale Orthopedics and Greenwich Hospital. Dr. Hickernell provides a range of services and procedures related to orthopedic and degenerative conditions of the hip and knee, including minimally invasive, muscle-sparing anterior hip replacement, total and partial knee replacement, and complex revision surgery on previously replaced or problematic joint replacements, or patients with periprosthetic fractures or infection of the hip and knee. He utilizes opioid-sparing multimodal pain control and enhanced recovery after surgery, otherwise known as ERAS, protocols to facilitate same-day discharges in appropriately selected joint replacement patients. He is a fellow of the American Association of Hip and Knee Surgeons and is actively involved in medical research with a focus on studying methods of pain control while reducing opioid consumption. His research is regularly published in journals, including the Journal of Arthroplasty and the Journal of American Association of Orthopedic Surgeons. He also regularly gives presentations at national medical meetings. Welcome, Dr. Hickernell.
Thank you for that introduction. So I have the dubious distinction of talking about revision surgeries. I say that because by nature of needing revision surgery means something hasn't gone quite right earlier. But unfortunately, it is something that is happening more and more as we're doing more and more surgeries in general. The numbers of revisions increase as well. So what is a revision surgery? Essentially, it's a redo of a previous surgery on a particular joint. We're obviously today talking about hip and knee replacements, but it could be after a previous fracture surgery, a conversion of a previous surgery. We'll talk about, how do you know if you need one and what are some of the things that could happen to lead to needing revision surgery, and a little bit about how are revision surgeries different than primary or the first time surgeries. So Drs. Chu and Mattern already gave great summaries about, knee arthritis and hip arthritis and the treatment options and, how the x-rays look. I mean, I agree with everything that they were saying, including the range of non-operative treatments that we go through first, which I'm going through again just because this is also relevant for revision surgeries. I mean, having a painful joint isn't necessarily a reason to have revision unless we can sort of identify what's wrong with it. But say you've already gone through these non-operative treatments, things aren't getting better. You've already had the partial knee replacement that has already been discussed, which can be on either the medial or lateral side of the knee or sometimes underneath the kneecap. or total knee replacements or total hip replacements, which most of the time, as Dr. Mattern was just talking about with knee replacements, are functioning really well. You know, greater than 90% are still going strong at, 15 to 20 years after surgery for both hip and knee replacements. So most of the time, things are great, and we kind of never look back. However, the rates of these surgeries are really going up as our patient or population in the country is getting older, the baby boomer generation. The rates of these surgeries are dramatically increasing with time, knees more than hips. And as we do more and more millions of these surgeries every year in this country, it just, means eventually there's going to be more revision surgeries as these things, can develop issues over time. So what are some of those issues? What are the reasons for potentially needing revision surgery? We'll talk about it. So some of the long-term concerns that the Drs. Mattern and Chu kind of already talked about a little bit are with the plastic pieces. So we use the modern plastic pieces that we use are much better, frankly, than they were really like 20 years ago. Around the year 2000, the manufacturing techniques for those plastics got dramatically better. Before then, the plastic pieces would wear down, just from the motion of everyday life, sometimes at up to, a millimeter a year. And if that was only, 10 millimeters thick, that's where that 10 to 15 year lifespan came from, which historically was true. But since around the year 2000, when we started using these new plastics, that really isn't happening anymore. This is a picture of a patient with an older hip replacement, and you can see how both of the balls are not really like centered in the socket. And that's because the plastic piece, which you can't see on the x-ray, has worn down with time. And that's allowed the ball to migrate up a little bit. And that's one of the things that can happen, over the long term with these joint replacements. Again, we don't see that much of that these days with the newer implants, but obviously there's still some older implants out there from people that had their surgeries, 25 years ago that can develop these issues. And that can lead to some osteolysis or bone loss, which is, that shadow you kind of see behind these sockets where the bone has started to erode away a little bit from an inflammatory response to that plastic debris as it breaks down. Another issue that can happen over time is loosening, where the implants can eventually get loose from the bone, which you can see a little bit. There's kind of a lucency between the bone and the cement and the implant here, which is one of the x-ray signs of that. This is a picture of one of those plastic pieces that wore out after like 20 years. This is an extreme case where it actually rubbed all the way through. Post-traumatic issues often, so these are some examples of different ways that, two different ways that a hip fracture can be fixed with implants that hold the fracture together. Sometimes after these surgeries, the patient goes on to develop severe arthritis, and that can be treated with a hip replacement, but it's a little bit more complicated in the revision setting where we have to take the implants out first. To basically make room for the hip implants, the hip replacement implants. This is just another way that hip fractures can be fixed, that if it doesn't succeed and the bone doesn't heal, or if the patient develops more arthritis, wear and tear arthritis in the future, that's potentially a reason to need to have that surgery revised to a hip replacement. Sometimes after we've done successful hip replacements or knee replacements, patients fall and have accidents and can lead to broken bones around the implants. Sometimes if the fracture is kind of distant enough from the implant bone interface, and if the implant hasn't gotten loose because of the fracture, sometimes we can just treat the fracture like a normal fracture and fix the bone with implants that hold it together so it can heal. But sometimes it means we have to revise the already replaced joint because the implants have been loosened from the bone by the fracture. And even if we get the bone back together, now the implants are loose and not functioning properly. So that's unfortunately a reason for needing revisions. The most common reasons these days is implant loosening, like I had discussed. These are some x-rays of a knee with some areas of lucency on x-ray around the implants, which are often one of the telltale signs that it's become loose. And this is another example with a hip, which also looks like it's sunk down into the bone, which is something you can tell if you look at previous x-rays and then follow-up x-rays. You can detect a change. Another common reason, relatively speaking, for revision is instability. So in a knee, that can refer to too much motion between the femur and the tibia, or too much motion between the implants. That can happen because if the implants were just perhaps not in an ideal position to begin with. Sometimes the ligaments can stretch out or become injured over time. And sometimes the implants loosening themselves can lead to some of that. With hips, hip replacements, when we talk about instability, we're often talking about the ball dislocating out of the socket, which can happen. Similarly, if the implants aren't in a perfect position, and sometimes over time things wear down, the plastic wearing down can be a reason for this to occur. So those are some of the most common reasons, along with infection. Sorry to put up this gross picture, but if a patient's knee ever looks like that, or any incision, you better call the surgeon right away, because infection is unfortunately one of the leading reasons for revision surgery. It's often difficult to pinpoint, how an infection gets in. Was it something that happened at the time of surgery that was slowly brewing for a long time? Sometimes it can get inside a joint from the bloodstream if there's an infection in the body somewhere else. But this, unfortunately, when this happens, often requires revision surgery because antibiotics alone often can't get the infection off of the implants. So we often have to do surgery to, unfortunately, sometimes take them out and put in new ones, often with a temporary antibiotic implant in there for a period of weeks to months to try to cure the infection before putting in new final implants again. So when this happens, it's a very big deal. That's why, our team here does everything we can to identify patients that have risk factors for infection and try to get them healthier before surgery as much as possible. So before, having revision surgery, reaching the right diagnosis is critical. I said earlier that just having a painful joint is not a good reason to have a revision. There's a lot of reasons why people might have some pain after joint replacement. Often it's a thing like tendinitis that can improve dramatically with conservative measures like anti-inflammatories, sometimes injections, physical therapy. So before committing to a revision, we really have to identify a mechanical issue essentially that we can fix with surgery. Once we've done that, there's a lot of careful planning that needs to be involved, looking at the x-rays or sometimes advanced imaging like a CAT scan or an MRI, and planning off that in terms of what we need, because every revision is a little bit different. The revision surgery really needs to target the patient's specific problem. Sometimes we even take x-rays during the surgeries to make sure everything's going the way we want at revisions. The implants tend to be different. So primary or first-time joint replacement implants tend to be a little bit smaller, and they get fixation at the bone, typically right around the joint surface. When we have to take those out to put in new revision implants for whatever reason, and there's, like we talked about, a bunch of reasons to potentially need that, we typically need to use longer implants that achieve fixation to the bone in different places than the original implants, because that bone has been compromised by the original surgery and removal of those implants. And so the implants tend to look different and tend to be a bit longer, like on these x-rays. Similar on the hip side, these are x-rays of a patient that had a fracture around the implant that needed to be changed to a longer one, and then there's cables around the bone to get that to heal back to the new implants. And these are the infection pictures I'd put up with a original primary implant on the left, and then a temporary implant in the middle that's looks skinny like that because it's coated with antibiotic cement, and then a new revision longer implant on the right. The furthest right picture with all those dots is a picture of a patient that had a hip implant removed completely And those are just little balls of antibiotic cement to try to cure the infection, which is occasionally what needs to be done temporarily or even permanently if the infection hasn't been cleared. The other guys had already talked about approaches. I mean, I agree there's many different ways to get to the hip joint, and at the end of the day, they all work. They all work well. Revision surgeries often require a little bit of a longer incision to get a wider exposure or visualization for the surgeon during the surgery to be able to see everything to fix the issue. Post-op is very much in an ideal situation similar to the primary joint replacement. We get patients up ASAP, ideally the same day as surgery, walking with our physical therapist here at the hospital. Elevation and icing is important for swelling and pain, which helps with pain control. We give medications to prevent blood clots, and we want people moving for that reason and also to prevent stiffness after the surgery. So I think I'll leave it there, turn it over to our anesthesia colleagues, unless anybody has any questions.
Thank you, Dr. Hickrnell. That was wonderful. This is the first time that we've had a discussion regarding revision surgery. So that was really, really informational. So thank you so much. All right. So next up, we have Dr. Gurney, one of our anesthesiologists that's going to give us some information about what to expect from a pain management and anesthesia point of view. Dr. Mark Gurney is a graduate of NYU Medical School in 2012. He then went on to complete his anesthesia residency at Cornell and his regional anesthesia acute pain fellowship at Columbia in 2017. So welcome, Dr. Gurney.
Hi, thanks so much. Happy to be here. So as she said, I'm going to be talking about anesthesia regarding total knee replacements and total hip replacements. And just a little bit about an overview of what I'm going to be talking about today. So first, I really want to address your concerns because this presentation is all for you. And then we'll talk about how we control the pain, how you go to sleep, anything you should do to prepare, and anything what you can expect. So here at Greenwich Hospital, we take a patient-centered approach to your treatment. And basically what that means is this is surgery, this is a big deal, and we understand that. And because it's stressful, you probably have a bunch of questions or concerns that you would like answered. So I'm going to try to make this a little bit more interactive. And if anyone has any questions or concerns specifically about anesthesia, please don't hesitate right now to type in that little box, and I'm more than happy to answer any questions. And if there aren't any questions and you just want a quick overview, that's also totally fine. But I'll just pause for like a couple seconds. Anybody? Well, if that changes, doesn't look like anyone has any questions, but if that changes, feel free to put that in the question box and I'll stop and answer your question right away. It's hard to be interactive on Zoom, I know, but you got to try. So first, people are most concerned about the pain after the surgery, obviously. So there are great techniques we can do to treat your pain. The first, even before you go into the operating room, I think Dr. Mattern talked a little bit about this, but we call them preoperative medications. And each surgeon has, we got a question. I am on blood thinners, and my cardiologist says for spinal anesthesia, I should be off Eliquis for 5 days. What is the risk of that? So with blood thinners are good for you if you have an abnormal heart rhythm or you had a blood clot in the past, so you don't want that to happen again. However, they're bad for surgery because they make you bleed more. And we also do spinal anesthesia, which is an injection in the back, which also, if a person's on blood thinners, we can't do that tiny injection because of the risk of bleeding. It can lead to all sorts of bad things like paralysis. So because of those scary things, we have you off blood thinners for surgery to reduce the risk of blood loss, and so that we can provide that spinal anesthesia, the injection in the back. And then after surgery, it's usually 24 hours. If everything is stable, and it usually is, then you go back on your blood thinners. Now, obviously, there's a risk benefit here, right? So the risk of being off your blood thinners is you can have, for example, if you have an abnormal heart rhythm, if you're off blood thinners, you could have a stroke. Now, the risk of that is pretty small when compared to the risk of bleeding during surgery. So that's why we have people off blood thinners for surgery. However, if you are high risk for these bad things to happen when you go off your blood thinners, what we do is we admit you to the hospital and we put you on a heparin drip, which is a medicine IV that is a blood thinner in itself, and then we turn it off 6 hours before surgery, and then you have your surgery, and then you're off blood thinners for just 24 hours, so that the time you're off blood thinners is much smaller. And I hope that answers your question. Okay, so back to pain. So we have great yes, thanks. No problem, Jane. So we have great techniques for pain management, non-opioid pain medicines, we generally focus on. So the first thing, actually the third thing I have written here is local anesthetic. But that is so important for pain management. We use that in two different ways. The first way is you're going to have a nerve block. And what that means is it's done outside the operating room. So right before you go into the operating room, we bring you to our block area. And in the block area, we give you some relaxing medicine through the IV, which is usually a combination of like an IV Xanax, with or without a little bit of IV pain medicine, usually a little bit of narcotic. And that makes you a little sleepy, kind of like in twilight. And then under ultrasound guidance, we find the nerve and inject numbing medicine or local anesthetic around that nerve. And that really numbs up that area that the surgeon is operating. In addition, the surgeon also uses local anesthetic during the operation, and he or she injects into the operative field where they're performing surgery, and that also helps numb up the area. Now, there's a new medicine, relatively new medicine. It's called Exparel. That's supposed to last up to 3 days and give you pain relief from that. So the surgeon also injects Exparel into the operative field, which is that's a relatively newer thing. So that's how we use the local anesthetic. We give you Tylenol before the operation, 1,000 milligrams of Tylenol, and then also NSAIDs. NSAIDs are like Advil, and some surgeons do this IV for 24 hours and switch to oral. Some surgeons give you oral NSAIDs in the beginning before you go into the operating room, and then continue it post-operatively. So, and all those are the three main ways we treat pain, and you combine all these things, and they synergistically or like exponentially add to each other to really control pain. Now, that being said, it is surgery. You will have pain, and that's normal. And the whole point of it is to make it tolerable. And if you need narcotics, that's okay too. It's not saying you shouldn't take narcotics. If you need narcotics to get through your physical therapy or do other things, then that's fine. Narcotics are fine to take in the short term for acute, for acute injury or acute trauma or surgery in the very short term. The problem with narcotics is when you take it for too long. And most people The surgeons could probably tell you more about this because they see you more often than I do. I just see you at the beginning of surgery and at the end. But most people don't take narcotics after a couple days. They're really fine with all these other pain regimens we have you on. Okay, so how do I go to sleep? So once you get the nerve block, you go to the operating room. And if you need more relaxing medicine, when you get to the operating room, we give it to you. And then there are two different ways you can be put to sleep. There are two different anesthesia techniques that we use. One is general anesthesia and one is spinal anesthesia. Spinal anesthesia is generally used for these type of surgeries because it allows you to breathe on your own. We don't put a breathing tube down your windpipe or anything like that. Basically, spinal anesthesia is what I alluded to with Jane's question, is spinal anesthesia is an injection in the back, in the spine, and we inject that local anesthetic that I mentioned previously into your spine. And it basically numbs up your legs from the belly button down. And basically, you won't feel anything for hours after we do that injection. So after you wake up after surgery, you may or may not be able to move your legs, and that's normal. And then over the next couple of hours, they'll totally come back. So, and then another way of doing anesthesia is called general anesthesia. And this is just completely asleep, breathing tube, and just how most anesthetics are done for most surgeries is just with general anesthesia. Now, that being said, with the spinal anesthesia technique, you are asleep during the whole operation because after we do the injection in the back, then that's when you go completely asleep. So from the patient's perspective, you're asleep either way. It's just a different way of performing the anesthesia. And how should I prepare? From an anesthetic perspective, there's really not much to prepare for, but if you could remove all jewelry and makeup, when I say makeup, especially around, like, no makeup around the eyes, because that can also lead to a corneal abrasion. A corneal abrasion is like a little scrape in your eye that can happen when you go unconscious. And it's more likely to happen if you have a lot of makeup. The makeup can get in your eye and kind of scratch the cornea. And it's not dangerous, but it is a nuisance and it can be painful. So it's a good idea to not wear makeup. And also follow fasting instructions. They can be a little confusing because we used to tell every patient not to eat after midnight, not to eat or drink after midnight, and just follow it, and it's just easier. It's just easier that way. But in reality, you can have clear liquids up until 2 hours before the surgery, and clear liquids, and they're basically any liquid you can see clearly through. So that includes water, apple juice. Most surgeons tell people they can have like 12-ounce Gatorade 2 hours before the procedure, and that basically it prevents nausea and vomiting. It helps you feel more awake after surgery. It helps with the electrolytes and the fluid imbalances. So it does all good things. The problem with it is confusing, and patients sometimes mess up the hours and things like that, but it's something we can all manage it if mistakes are made, and mistakes happen, and we understand that. But basically, you could also have coffee with no milk, black coffee only, and that counts as a clear. So like, it is a little confusing, and we understand that, but definitely have a Gatorade 2 hours before your surgery, and you'll feel a lot better. So I just want to run how the day is going to go, so you know what to expect. So the first step, you get to the hospital and you go to the ASU, which is the ambulatory surgical unit. And in the ambulatory surgical unit, you'll meet your preoperative nurse. They'll ask a bunch of questions. They'll place an IV. That's where you'll meet your anesthesiologist also in ASU. We'll ask you the same questions. Patients usually say, you asked me that already a while ago, but I need to know. So, sorry, so many repetitive questions. It's just one of those things. So then after ASU, after all those T's are crossed and the I's are dotted, you go to the block area, which is where you get your nerve block. If for some total hip joints, I should say, we don't do nerve blocks. It is surgeon dependent. So if you are getting a total hip, you may or may not get a nerve block. It depends. So you'll go to the block area if you are getting a block. Then after the block area, you'll go to the operating room where you will most likely get spinal anesthesia. Oh, and I should say there's no right or wrong decision with spinal versus general anesthesia. It is patient dependent, and if, for example, if some people have back problems and they don't want anyone going, they don't want a needle going anywhere near their back, that's totally fine, and we totally understand that. General anesthesia is a perfectly safe, effective option. So you'll, after the spinal anesthesia, you'll go to sleep, or you'll go to sleep right away with general anesthesia. After that, you'll go to the PACU, which we have great nurses, very caring, attentive nurses who their number one job is to make sure that you're comfortable. So most likely you won't be in pain afterwards because you'll be under the spinal anesthesia will still have effect. So most likely you won't have any pain and you'll be feeling pretty good. And I should also say we give you a bunch of medicines to prevent nausea and vomiting. Nausea and vomiting is a pretty big thing after anesthesia. But with these type of anesthetics, with the spinal anesthesia and with all the medicines that we give you, it's typically not seen after these type of surgeries because of our anesthetic technique. And then, so once your pain, if you have any, is treated, and your nausea is treated if you have any, most likely not, and you're completely awake and your spinal is wearing off and you can wiggle your legs a little bit, then you'll either go home after physical therapy or you'll be admitted to the hospital. And that is it.
All right. Thank you so much, Dr. Gurney, for that presentation. Our pain management team is so critical to a successful joint replacement surgery. So thank you for highlighting all of the great advances we've made over the last several years. Next, we have Nicole Rossi, who will take us through what to expect from a physical therapy standpoint, both in the hospital and beyond. So Nicole has her doctorate in physical therapy. She's been an inpatient physical therapist at Greenwich Hospital for 5 years after beginning her career in home care. She received her undergraduate and doctoral degrees from Quinnipiac University. So I will be handing it over to Nicole.
Thank you, Annie.
You're welcome.
Okay, so bear with me here. Why is the next slide? It's the next slide. Hold on. Okay. So just a brief overview of what I'm going to talk about. We're going to discuss the goals of physical therapy, some preoperative exercises, how to prepare for your surgery, and also the length of the therapy process. So goals of rehab following total joint replacement. The main goal is to restore your functional independence, learning transfers and walking with an assisted device. Based on your surgery and how you're progressing, you may be starting off with a rolling walker and then progressing to a cane or crutches. To gain functional strength and your joint mobility. Also, a main goal, which we've been stressing already, is early mobilization. So with that, preventing complications of bed rest, which can include blood clots, pneumonia, and muscle weakness. And also patient education. We provide you education throughout the entire therapy continuum. So when I mention exercises, these are some of the exercises that you may be given preoperatively. So just a brief description. So ankle pumps, so just pointing and flexing your toes up and down. Quad sets, also knee presses, just tightening that quadricep muscle in the front of your thigh. Buttock squeezes or glute sets. Heel slides, if you're laying on your back, you're bending your knee, sliding your heel towards your buttock up and down. Hip abduction, moving the leg out to the side and back into the center. And then straight leg raises, which can be pictured below here. And then we're not discussing shoulder replacements here, but those are different exercises that will be done. Okay, what should you do to prepare for your surgery? So like I said, a lot of people have been doing prehab, so performing those preoperative exercises for strengthening. The better shape you're in and those muscles are before surgery, generally the faster the recovery will be. We also recommend doing aerobic exercise, about 15, 30 minutes, 5 times a week as tolerated. And also a benefit would be if you are able to lose weight before your surgery, it will help reduce the pressure on your joint. So preparing for the surgery. So I'm sure you'll hear more about it in a little bit, but plan to attend the preoperative class. It's very helpful, a lot of information, gives you all the information on all the equipment and everything you'll need. You want to arrange for a recovery coach or a caregiver to help assist you for at least 1 to 2 weeks following your surgery, just so you have extra assistance if you need it. You also want to purchase your equipment, which would include, pictured below, a rolling walker, a straight cage, a commode, and a hip kit might be needed for those patients that if they have posterior hip replacement and have hip precautions. Now, therapy is a continuum. The whole process lasts about 8 to 12 weeks. So throughout that whole process, the goals that you'll be working on are normalize your walking pattern, so progressing from a walker to a cane to no assistive device, improving your weight bearing through that joint, your range of motion in that joint, improving your balance, strength, and endurance. And then lastly, if you guys do sports or anything, whatever activities you like to do, returning to those activities and overall improving your quality of life. Now, just here's a brief outline of what it could be. So your inpatient hospital stay, I write 1 to 2 nights, but more frequently, most patients only have to stay 1 night, and then they're able to leave the next day after their surgery. Then from the hospital, generally, some people may go straight to outpatient physical therapy, and they'll do that for 2 to 3 times a week for 6 to 8 weeks. Most people will go home and receive home PT for 1 to 2 times a week and then continue with outpatient physical therapy. And least likely nowadays, people will go to short-term rehab. From the hospital, their stay is typically 5 to 7 days, possibly less, and then from there, sometimes go home and then go to outpatient PT or outpatient physical therapy from there. And then conclusion, so goal, like I believe Dr. Mattern said, be an active participant in your recovery process to maximize the success of your new joint replacement. Thank you.
Thank you so much, Nicole. It really is critical that our patients are engaged in the recovery process. So thank you for that overview.
Yeah, okay.
Now we'll move on to Lauren Boyarsky, our total joint replacement coordinator here at Greenwich Hospital, who will give an overview of the total joint replacement program as a whole, as well as highlight the individualized care that patients receive at Greenwich Hospital. Lauren serves as our total joint replacement program coordinator and has over 15 years of experience as an inpatient physical therapist. In 2022, Lauren helped to lead the total joint program at Greenwich Hospital in achieving advanced certification by the Joint Commission. Lauren is passionate about the importance of a team approach in helping our patients succeed in their joint replacement journey. Lauren?
Thanks so much, Annie. Good evening, everybody. I'm going to give you a little bit of the overview of our total joint replacement program here at Greenwich Hospital. This is just a slide that demonstrates our vision, mission, and values. As you can see under our values, patient-centered care is one of the things that we highlight the most, and that will be very apparent. I think it's been very apparent tonight, and it'll definitely be more apparent once I describe our program to you. So the mission statement of our program is the Center for Joint Replacement at Greenwich Hospital is a comprehensive program committed to providing excellence throughout the continuum of care to patients and their families. So how do we do this? How do we achieve that mission statement? So as you can tell, tonight we've had several speakers who have shown they're very highly skilled, highly experienced, in all of their fields. So we provide multidisciplinary care in a safe patient-centered setting. So really the goal of our program is we want to make sure that we are achieving the goals that you want to achieve, right? This surgery, while it is a very big deal, of course, this is a well surgery. So you're coming into this surgery to try to get better, to try to improve your quality of life. So we want to tailor your approach to your recovery, to your needs. We provide continuous education for both the patient and their caregivers, which includes classes to educate you on the surgery process itself before your surgery begins. We also provide education while you're here in the hospital and throughout the recovery phase, even beyond your discharge from the hospital. We provide effective pain management options like Dr. Gurney described to help every patient maximize their level of function and the success of their surgery. We also use non-pharmacological treatments and interventions that help to treat the mind, body, and spirit during your recovery. So as the program coordinator, I'm very much involved in developing and growing this program. We have performance improvement plans and goals each year that help us to comply with the highest quality standards that are set forth by the Joint Commission, which is one of the regulatory bodies that comes every couple of years to evaluate our program. We also work closely with 3 nurse navigators, and the role of a nurse navigator is to help provide that personalized education and support throughout the joint replacement experience. These nurse navigators get in contact with patients about a month to 6 weeks prior to surgery, and the role of that navigator is really to ensure that your health is optimized prior to surgery. Because this is a surgery that is improving your quality of life, we want to make sure that you are as healthy and well in order to go through this whole process, the surgical process, and have a successful outcome. We want to ensure a positive experience throughout the continuum of care, again, before, during, and after your surgery. As Nicole mentioned, and as some of the other surgeons mentioned as well, we do a lot of education prior to the surgery. So we offer a weekly class for hip and knee replacement patients. It's taught by either myself or one of the nurse navigators. And there's a couple things that we highlight during this pre-surgery class. The first thing that we highlight is how to prepare you for your surgery. So number one, we have to make sure that your body is prepared. So like Nicole mentioned, doing those preoperative exercises. We also talk about that preoperative hydration that Dr. Gurney mentioned, making sure you're hydrated, coming into the hospital. We also talk about how to prepare your home. Over 90% of our patients go directly home the day after their surgery. So we want to make sure your home is a safe environment and you have everything you need, again, to make sure that that recovery process is a success from day one. We also talk about what to expect on the day of your surgery. So when you come into the hospital, where do you go? Who will you meet? What will you expect during that preoperative process as you prepare to go into surgery? What will you expect when you're in the operating room, once you're in recovery, and then, of course, once you come out of surgery and you go to the surgery unit? We also talk about what to expect once you're on the surgery unit, seeing our physical and occupational therapists, talking to our case managers about discharge. And then we also really one of the biggest things is we talk about discharge before you even come into the hospital. It's imperative that you have a plan for your discharge before you even have the surgery. We want to make sure you are well prepared and you know what to expect so your recovery can continue successfully at home. So why should you choose Greenwich Hospital? I think we've done a pretty good job of telling you why so far. Number one, you've heard from 3 of our outstanding surgeons tonight. Again, these are highly experienced surgeons, a lot of years under their belt in terms of performing these surgeries and perfecting their techniques. So in addition to our surgeons, we have a very cohesive multidisciplinary team. So this includes Dr. Gurney and the team of anesthesiologists here at the hospital. This includes our nursing staff, our physical and occupational therapists, our case managers who help to facilitate your discharge, and of course, our total joint replacement team. Everyone is here to offer you personalized and compassionate care. Because most patients go directly home after the surgery, again, This is a well surgery. We want to make sure that you are as healthy and ready to undergo this procedure as possible. We have unmatched outcomes. Our complication rates and our readmission rates are well below the national average. And also, as Dr. Mattern mentioned, our rates for patients needing transfusions after surgery are less than 1%. In addition, like Andy mentioned, we did recently achieve the Joint Commission's highest level of recognition. This requires an incredible amount of coordination of care. So I want you to know that our teams are in constant communication with each other. Our teams at the hospital are in communication with your doctor's offices before, during, and after the surgery, again, to make sure this is a seamless process. And again, we also have that comprehensive patient and caregiver education, which is so important in order to make you feel prepared to undergo this procedure. We look forward to caring for you, and thank you for choosing Greenwich.
Thank you so much, Lauren. That was a great overview of the fantastic program here at Greenwich. All right, lastly, we will hear from Jennifer Feely regarding the unmatched nursing care you can expect from us here at Greenwich Hospital as well. Jennifer is the Assistant Nurse Manager of the Inpatient Surgery Unit at Greenwich Hospital. She was awarded the inaugural Daisy Leader Award for providing compassionate leadership and creating a caring environment. She was a bedside nurse on surgery before transitioning into her leadership role. During that time, Jennifer was also the co-chair of the Unit Practice Council, leading initiatives focused on patient safety and patient and staff satisfaction. All right, I'll hand it over to Jen.
Thank you, Annie, for that introduction. Good evening. I'm delighted to be a part of this esteemed panel and share what to expect during a patient's stay on the inpatient surgery unit. Just looking to our vision, missions, and values, our nursing care aligns with these, specifically providing compassionate, patient-centered care by prioritizing patients and their families, having respect for all, and having the accountability to do the right thing every time. Care is coordinated in a team-based approach where multiple disciplines collaborate to help patients achieve their goals. Doctors, PAs, nursing, physical therapy, OT, pharmacy, and case management. Your comfort is a top priority for us, so we take a multimodal approach, which I know we've discussed previously, but it's a combination of pharmacological and non-pharmacological interventions to help you maximize your functionality, which is, your ability to participate in physical therapy. We utilize a combination of pain medications, which will be used in order to minimize your opioid use. Cold therapy is used via ice packs. And there are other options from our comfort menu, including healing touch. Our goal is for early mobilization on the day of surgery with physical therapy and nursing. And we've seen the benefits being decreased pain, length of stay, risk of postoperative outcomes, and overall improved outcomes such as flexibility. Your discharge will be planned efficiently and safely and coordinated by your team of doctors, PAs, case management, nursing, physical therapy, and pharmacy. Your discharge instructions are individualized with very detailed education next steps and a review of any questions that you have. PT services and any equipment and supplies that are needed will be arranged for you. Medications will be reviewed, new medications plus existing home medications, and all prescriptions will be sent to your pharmacy. Safety is a top priority on the unit and at home, so safety education will be reinforced throughout your stay. All ambulation will be with a staff member, whether it's nurse, nursing assistant, or physical therapy. Our hourly rounding will be performed in order for you, to maintain your safety and comfort. Guidance with assistive equipment will be given, as well as education how to prevent the falls at home. Greenwich Hospital Nursing has been awarded Magnet with Distinction Recognition, which is the gold standard of nursing. We're nationally recognized as a top-tier organization with the highest level of nursing care. Our nursing vision is achieving excellence through continuous improvement and innovation. Thank you.
Fantastic. Thank you, Jen. All right. Well, I want to thank all of our presenters for really giving some fantastic overviews of what people can expect with this type of surgery, with these types of surgeries. We do have just a couple questions before we close out the program, so I just want to ask a couple questions of our group. So one of the questions I'm going to start with is we've heard a lot tonight about a lot of changes in terms of post-op recovery and that they've contributed to a shortened length of stay. Several years ago, people were expecting to stay in the hospital at least for 2 or 3 nights. Dr. Chu, can you talk about what's changed? Is this insurance driven or is this really because patients are doing better?
Thanks, Annie. That's a really good question. It really has been a change in terms of, I think I mentioned this before, the team-based approach to care and the transition away from what we used to call like a sick patient model to the well patient model. So recognizing that patients who have these replacements are not ill, but just on the road to recovery, really lets us focus in on getting them mobilizing early and then being discharged often to home. Really isn't driven by insurance, is really driven by quality.
Excellent. Great answer, Dr. Chu. Along the same lines, a question for Dr. Hickernell was that why is home better than going to rehab?
So I talk about this a fair amount in the office. I think a lot of patients have the perception that rehab is this like Olympic training facility. But when we're talking about rehab after a joint replacement like this, we're talking about a nursing home. That's in reality what we're talking about. Where you'll get physical therapy, usually like an hour a day, and the rest of the time you're sort of encouraged to stay in your chair or bed, because of like fall liability. So I think counterintuitively for some, going home actually encourages. You have to get up to go to the bathroom to get your own medication, which you can safely do after a joint replacement. So I think patients actually move more when they go home, and it's safe and they're more comfortable. You don't have to wait for a nurse, at a rehab to bring you your medication. You can just get it when you want it. So patients are happier at home. And that's been borne out in research studies too, that, going home has not jeopardized outcomes. If anything, they're better now than ever.
And there's definitely something to be said about sleeping in your own bed and eating your own food, right? All right, one for Dr. Mattern. We had a patient that is thinking about getting both knees replaced at the same time, but has heard that it's a little risky. Can you explain why it's a little bit more risky and who makes a great candidate or a good candidate?
Sure, that's a great question. So, when making the decision for someone who has arthritis, say in both knees or both hips, if the arthritis is similar in both joints, sometimes it is just easier to undergo one operation. The recovery, I tell patients, it doesn't double your recovery time. If it takes you like 6 weeks to get back to most of your regular activities after like a hip replacement or knee replacement, it doesn't make it 12. It increases it a little bit, but it certainly doesn't double it. There are a lot of studies that show that the risks of surgery, we didn't talk a lot about risks of surgery, but there's risks of blood clots and we try to prevent those. And there's risks of like cardiac events, all again, not common. Those risks do go up a little bit with doing simultaneous, meaning in one OR setting, doing both knees or both hips at the same time. So I think it really just boils down to patient selection. I think if you have like a young, healthy, motivated patient with bad knee arthritis, it's sometimes more beneficial to do both at the same time because one knee gets straight and the other knee stays crooked. It can actually cause the newly fixed knee, if both aren't treated, to get stiff again. So I think it boils down to overall patient health. So you have to be in pretty good shape to do it.
All right, wonderful. Thank you, Dr. Mattern. Well, that brings our presentation to an end. Thank you all for participating. I really appreciate all of your time. And thank you to those of you that joined us this evening. If you want any more information, please check out our website at greenwichhospital.org. And we look forward to seeing you in the future. I hope everyone has a great night.
Thanks, everybody.
Thanks, everyone.
Bye, everyone.